Welcome, curious minds and future healthcare heroes, to the deep dive. Today, we're plunging into a topic that's, well, absolutely foundational for nursing students: understanding problems of oxygenation and perfusion.
It really is.
Our mission is to give you a crystal clear shortcut to the most crucial medical surgical concepts here. We want to connect the theory to real world practice, prep you for scenarios, and yeah, even help you get ready for those big exams like the NCLEX.
Exactly. Think of oxygenation and perfusion as the lifeblood of patient care. Seriously. Without adequate blood flow, without that consistent delivery of oxygen and nutrients to every single cell, every system in the body is at risk.
Makes sense.
So we're going to explore how various conditions disrupt this vital process and, maybe most importantly, what that means for your patient care. We want to give you the tools for critical thinking, for pattern recognition.
Okay.
Let's imagine we're caring for a patient today. Let's call her Mrs. Evans. She's 68, admitted with worsening shortness of breath, swollen ankles, history of high blood pressure, had a heart attack a few years back.
Okay, classic profile.
Right, so as we deep dive today, keep Mrs. Evans in mind. Every concept we touch on will help you understand her situation, her complex needs, and how you, as her nurse, can make a really crucial difference.
Okay, sounds like a plan. Let's unpack this then, starting right at the core, the cardiovascular system. Picture your heart as this intricate, tireless pump.
Nonstop.
Deoxygenated blood comes into the right side, gets pumped to the lungs, picks up oxygen. Then that fresh oxygenated blood returns to the left side.
Right.
And from there, bam, it's powerfully ejected into the aorta to circulate through the entire body. We're talking 4 chambers, 4 valves, all working in perfect harmony, making sure blood only goes one way. It's an incredible loop, really.
And that harmony isn't just plumbing, right? It's powered by an amazing electrical system. The heart's conduction system, it's like its internal spark plug, starts at the SA node.
The pacemaker.
The natural pacemaker, yeah. This electrical impulse travels through the atria, down to the ventricles, and triggers this synchronized contraction and that electrical activity. That's precisely what we see on an electrocardiogram and ECG.
That's right. Remember the P wave. That's the atria depolarizing, getting ready to contract.
Yep.
Then the QRS complex, that big spike, that's the ventricles depolarizing.
Contracting.
The powerhouse.
And finally, the T wave is the ventricles repolarizing, the relaxing, refilling. The intervals between these waves are like timing checks.
Yeah.
They show how long the signal takes to travel. Any changes there can be a red flag.
Definitely a clue.
And these electrical signals, they drive the mechanical activity, systole, when the heart muscle contracts to eject blood,
Squeeze.
and diastole, when it relaxes and fills back up.
Relax.
How much blood the heart pumps in a minute. That's its cardiac output, or CO. Simple formula, right? Stroke volume times heart rate.
Simple, but crucial. And 2 key players affect that stroke volume. Preload. That's the volume stretching the ventricles right at the end of diastole, just before the next beat.
The stretch.
Yeah, think of it like stretching a rubber band. Not enough stretch, weak snap, too much stretch. It gets floppy. The heart needs that just right stretch for a good pump.
Got it.
Then there's contractility. That's the actual force of that contraction. Your sympathetic nervous system can boost that. And the heart's ability to ramp up when needed, like during exercise, that's its cardiac reserve.
Okay.
And all this works together to maintain blood pressure, which is basically cardiac output times systemic vascular resistance, or SVR.
And as nurses, you are the first line of assessment. You'll physically check pulses rate, force, any rigidity, capillary refill, that quick check, less than 2 seconds.
Quick snapshot of arterial flow.
Exactly.
Yeah.
And you'll listen, auscultate, for brutes, that whooshing sound in narrowed vessels, or murmurs, those turbulent heart sounds. These are your hands-on clues. And beyond the hands-on, we have more sophisticated tools like hemodynamic monitoring. This can mean invasive arterial lines for continuous BP readings, or even pulmonary artery catheters. Those give us direct measurements of pressures like PELP and CVP, telling us about cardiac output, preload, afterload.
So more direct numbers.
Yes, but there's a huge nursing responsibility here.
Yeah.
Zero referencing. You absolutely have to zero the transducer to the phlebostatic axis.
Explain that axis again.
Sure. It's essentially the level of the heart's atria. Usually you find it at the 4th intercostal space, mid-axillary line. You mark it on the patient. Getting that zero baseline correct is vital, because even if the patient just shifts position slightly,
Throws off the readings.
totally, it can skew your pressure readings, and that could lead to wrong clinical decisions. So what's fascinating here is that this foundational understanding, it isn't just theory for an exam, it's the lens. You know, the lens you'll use to interpret every patient assessment, every bit of data, it's the normal you'll constantly compare against.
Okay, so that's the ideal picture, the perfectly working system. But what happens when things go wrong, when perfusion gets disrupted? Let's switch gears and talk about some common conditions, starting with one our patient, Mrs. Evans, is dealing with right now. Heart failure. She's got the shortness of breath, the swollen ankles. What exactly is heart failure?
Right. Heart failure or HF, it's essentially when the heart just can't pump enough blood to meet the body's metabolic demands. It's not that the heart has stopped.
Right, it's still beating.
It's still beating, but it's become an inefficient pump. It can be
Mhm.
left-sided where fluid backs up into the lungs that causes the shortness of breath Mrs. Evans has,
Okay.
or it can be right-sided, causing fluid to back up into the body systems. That leads to peripheral edema, those swollen ankles,
Mm-hmm.
and, well, often patients have both. Biventricular failure.
And physiologically, what's actually happening inside the heart to make it fail like this?
Well, initially the body tries really hard to compensate. The sympathetic nervous system kicks in, right?
Yeah.
Increases heart rate, contractility, trying to keep that output up.
Fight or flight response.
Sort of, yeah. And the kidneys activate the RAAS system, trying to hold on to salt and water to boost blood volume. The heart muscle itself might dilate, stretch out to hold more blood, or hypertrophy, get thicker to pump harder.
Seems like good adaptations.
Initially, maybe. But here's the catch, the really crucial insight. Over time, these very compensatory mechanisms actually end up harming the heart further. They lead to remodeling. The heart gets stiff, less elastic, and ultimately even less efficient. It creates this vicious cycle that just makes the HF worse.
Wow. So the body's attempt to fix it backfires.
Exactly. It's like constantly redlining an engine. Eventually, it just wears out faster.
So those symptoms we see in Mrs. Evans's dyspnea, her edema, they're direct results of that decreased cardiac output and the fluid backing up. What are some key things nurses need to watch for?
Beyond the obvious shortness of breath and edema, you need to ask about paroxysmal nocturnal dyspnea, PND. That's waking up suddenly gasping for air.
Scary for the patient.
Very. Or orthopnea, needing to sleep propped up on pillows just to breathe comfortably. Fatigue is a huge, often overlooked symptom. And listen for that specific S3 heart sound and crackles in the lungs on auscultation.
Okay, assessment priorities. What about management?
Nursing management is huge. Daily weights are absolutely critical. Same time, same scale, same clothes if possible. It's the best indicator of fluid retention.
Number one thing.
Definitely. Strict sodium restriction, usually around 2 grams a day. And you have to teach patients how to read nutrition labels. It's not intuitive for everyone.
Good point.
Fluid monitoring, tracking intake and output carefully. And meticulous medication adherence is vital. Diuretics, ACE inhibitors, ARBs, beta blockers, they all play a role.
And crucially.
You have to teach them when to call the doctor or nurse practitioner. Red flags like a rapid weight gain, say 3 pounds in a day or 5 pounds in a week, or worsening shortness of breath. That's classic NCLEX style critical thinking.
Yeah.
Patient education for self-management.
Right. And for patients with more advanced HF, there are devices, therapies.
Yes, for sure. We have things like cardiac resynchronization therapy, CRT.
Yeah.
That's a special pacemaker that helps both ventricles beat together more efficiently.
Okay.
Implantable cardioverter defibrillators, ICDs, these are for patients at high risk of lethal heart rhythms. It's like having a tiny internal defibrillator ready to go.
Life-saving.
Absolutely. And for really critical situations, maybe temporary support, we might use mechanical assist devices like an intra-aortic balloon pump, an IABP. It helps reduce the workload on the heart, reduces the resistance it pumps against, that's afterload, and improves blood flow to the heart muscle itself. It buys time, gives the heart a rest.
Okay, very complex stuff. Let's shift to another major perfusion problem. One, Mrs. Evans also has a history of an acute coronary syndrome, ACS. That includes myocardial infarction, MI, a heart attack. What happens when the heart muscle itself starts to starve for oxygen?
Yeah, this is a true emergency. An MI is an abrupt stop in blood flow to part of the heart muscle. That lack of oxygen leads to necrosis, cell death. It's irreversible damage if flow isn't restored quickly.
And the cause is usually?
Usually atherosclerosis, those fatty plaques build up in the coronary arteries. If one ruptures, a blood clot forms right there, blocking the artery.
Okay. And you mentioned different types, STEMI and STEMI.
Right. We look at the ECG. A STEMI shows ST segment elevation. That typically means a complete blockage of a major coronary artery. It's a code level emergency. The goal is to open that artery, usually with PCI, within 90 minutes. Time is muscle.
PCI, percutaneous coronary intervention, angioplasty.
Exactly. Angioplasty and often stenting. Then there's anstemy, non-ST elevation MI or unstable angina. Here, the ECG doesn't show that specific ST elevation, usually meaning a partial blockage or blockage of a smaller artery. Still serious, still needs intervention, typically cardiac catheterization within, say, 12 to 72 hours. But the immediate push isn't quite the same as STEMI.
Okay. When you think MI, most people picture that classic crushing chest pain, but you mentioned nuances earlier.
Absolutely. While that crushing substernal pain, maybe radiating to the arm or jaw, is classic, you have to be vigilant, especially for your female patients, older adults, or those with diabetes. Their symptoms can be much more subtle.
Like what?
Fatigue, just profound fatigue, shortness of breath, maybe just indigestion or discomfort in the jaw, neck, or back. It's easy to miss if you're only looking for Hollywood heart attack pain. Recognizing these atypical presentations, that's critical nursing. It can literally save a life.
So important to remember.
You also often see signs of sympathetic nervous system activation, sweating, cool, clammy skin, maybe increased heart rate and blood pressure initially, and sometimes signs of heart failure pop up quickly, like that shortness of breath.
So if you suspect an MI, what are the immediate actions, the nursing priority?
Okay, think emergency department. First-line treatment, if the hospital have a cath lab and can do it fast enough, is that PCI we talked about, open the artery.
And if not?
If PCI isn't readily available, then thrombolytic therapy, clot-busting drugs might be used. But PCI is generally preferred if possible. As a nurse, your immediate priorities. Pain relief is huge. Morphine is often used. Continuous ECG monitoring is essential, looking for dangerous dysrhythmias like VTach or VFib, which are common complications.
Right.
And providing oxygen, aspirin is ordered. That MONA acronym, morphine, oxygen, nitroglycerin, aspirin, is a good starting point to remember, though protocols evolve. Plus, immense emotional support. It's terrifying for the patient.
Absolutely. Okay, so we've talked heart failure, heart attacks, but perfusion isn't just the heart, right? It's the whole network. What about problems out in the periphery? Let's talk peripheral artery disease, PAD. Mrs. Evans, with her history, is likely at risk for this too.
Very likely. PAD is basically atherosclerosis, that same plaque buildup, but happening in the peripheral arteries. Most often, it's the legs.
Same disease process, different location.
Exactly. And the classic symptom, it's intermittent claudication. This is ischemic leg pain, often described as cramping or aching, that comes on predictably with walking or exercise,
Okay.
and is consistently relieved by rest. Stop walking, pain goes away. Start again, comes back after about the same distance. It's the leg muscles screaming for more oxygen than the narrowed arteries can deliver during exertion.
Makes sense. And if it gets worse?
As it progresses, patients might develop rest pain even when not exercising, especially at night when lying flat, and eventually critical limb ischemia or CLI. That's severe blockage leading to pain, non-healing ulcers or wounds, and potentially gangrene, limb-threatening.
How do we usually diagnose PAD?
A key non-invasive test is the ankle brachial index, the ABI. You compare the systolic blood pressure measured at the ankle with the systolic pressure in the arm. A lower pressure in the ankle suggests blockage.
Simple but effective. And the nursing role in managing PAD?
It's huge, especially around risk factor modification. Number one, tobacco cessation. Smoking is incredibly damaging to blood vessels. It's the single most important thing a PAD patient can do.
Gotta hammer that home.
Absolutely. Then, structured exercise programs. Walking, despite the claudication within limits, actually helps the body build tiny new blood vessels around the blockages, collateral circulation.
Interesting. The body adapting.
It tries. And meticulous foot care is crucial. Patients may have a decreased sensation, poor healing. A small injury can become a major problem. So, proper footwear, daily inspection, seek a podiatrist. It's all part of that collaborative care plan you help manage and teach.
Okay. Lots of patient education there. Now let's consider the ultimate endpoint, the most critical failure of perfusion. Shock. What is shock, fundamentally?
Shock, at its core, is a syndrome. It's characterized by inadequate tissue perfusion, meaning the cells throughout the body just aren't getting enough oxygen and nutrients to function properly. Cellular metabolism goes haywire. All roads of severe perfusion failure from different causes can ultimately lead to shock.
So different types, but the same endpoint.
Exactly. You have hypovolemic shock, not enough fluid volume, maybe from hemorrhage or severe dehydration.
Volume.
Right. Then cardiogenic shock, the pump itself fails catastrophically. Think massive heart attack, end-stage heart failure. Mrs. Evans, if her HF worsened dramatically, could be at risk.
Or pump failure.
Then there's obstructive shock, something physically blocking blood flow, like a large pulmonary embolism or cardiac tamponade, where fluid squeezes the heart.
A blockage.
And finally, distributive shock.
Here.
Here, the issue isn't necessarily low volume or pump failure, it's massive vasodilation. The blood vessels get too wide, blood pressure plummets, and blood flow becomes poorly distributed.
Okay, examples.
The big one is septic shock from overwhelming infection. Also, anaphylactic shock from severe allergic reaction and neurogenic shock, often from spinal cord injury. In septic shock, even if you pour fluids in, the leaky dilated vessels and impaired heart function mean the oxygen still isn't getting delivered effectively to the tissues. It's like a swampy delivery system.
Got it. So, in any kind of shock, what are the absolute immediate nursing priorities?
ABCs. Always.
Yeah.
Airway, breathing, circulation, that's paramount. Then, rapid fluid resuscitation is often key, especially in hypovolemic and septic shock, pouring in crystalloid fluids like normal saline to boost volume and pressure.
Fluids, fluids, fluids.
Often, yes. Vasopressors medications like norepinephrine are frequently needed to constrict blood vessels and support blood pressure. Supplemental oxygen is crucial. And critically, you have to identify and treat the underlying cause. Is it bleeding, infection, pump failure?
Right. Treat the cause, not just the symptoms.
Exactly. And your role as the nurse. It's vigilant, constant monitoring, watching for subtle changes in mental status, urine output dropping off, skin becoming cool and mottled, bowel sounds disappearing. These are signs that organs aren't getting perfused.
So hyper-aware.
You have to be. Because shock can spiral. The body's massive inflammatory response, especially in sepsis or after major trauma, can become dysregulated. This leads to systemic inflammatory response syndrome, and if that continues unchecked, it can progress to multiple organ dysfunction syndrome, MODS, where one organ system after another starts to fail: lungs first, usually, ARDS, then kidneys, liver, gut. It's often the final common pathway. A huge part of critical care nursing is actually preventing infections, managing fluids carefully, acting quickly on subtle changes to stop that cascade before it leads to MODS.
Wow. That really ties everything together, from a simple electrical impulse to multi-system failure. That was truly a deep dive into oxygenation and perfusion. We've seen how it all connects the heart, the vessels, the body's response, impacting patients like Mrs. Evans at every level.
It absolutely does. It's a journey that really highlights how interconnected the human body is, and it underscores the immense responsibility, but also the incredible impact the nurses have. As future nurses, your ability to take all these concepts, the basic anatomy, the pathophysiology, recognizing those subtle signs of trouble like in HF or shock, and integrate them. That's what saves lives. That's what improves patient outcomes. It's not just about memorizing facts from a textbook. It's about developing that critical thinking, that pattern recognition. Always asking, is my patient perfusing adequately? And connecting everything back to that central idea.
So, what does this all mean for you, our listeners? Well, consider this. We live in an era of increasing medical complexity. Patients like Mrs. Evans often have multiple overlapping issues. How will you, as a vigilant, informed nurse, move beyond just reacting to problems of oxygenation and perfusion? How will you proactively anticipate and maybe even prevent them, especially for your most vulnerable patients? The challenge is definitely ongoing, and honestly, your learning should be too. Thank you for joining us on this deep dive.